welcome back to Psychiatry Bootcamp. Of all the episodes we've done so far, this one is the most personally relevant to me. When we recorded this, I had a 3-week-old infant at home who had gastric reflux and was miserable while eating and just generally not happy to be out of the womb. And I had a lot of moments during the recording where Dr. Wichman would share some expertise, and I would think, wow, that's my actual life right now. And later in the episode, I do use the word countertransference to describe how the conversation is making me feel. And I just want to say to all of our psychotherapy purists out there, don't at me, okay? I realize that I'm taking this term a little bit out of context, so please forgive me. In this episode, we're going to discuss a general psychiatric approach to patients who are considering pregnancy, are currently pregnant, or have recently given birth. I think one thing the episode does well is we talk about the general framework for making these decisions and point you to some validated resources to help you when you are having to make these clinical decisions. We also do go over some common clinical scenarios and hear Dr. Wichman's expertise. Today, I have one of my 4th-year medical students joining me who just completed a month on the consultation liaison service with me and was vocal about her passion for reproductive psychiatry. So I invited her to help out with the episode and join us. Erica, could you please introduce yourself to our audience?
Hi, everyone. My name is Erica Browne. I'm a 4th-year medical student currently at St. Louis University School of Medicine, and I'm happy to be here.
And our expert guest, Dr. Christina Wichman.
Hi, everybody. I'm Christina Wichman. I am a professor of OBGYN and psychiatry at the Medical College of Wisconsin, where I'm also the co-director of women's mental health, as well as the medical director of the Periscope Project.
I know you're a busy person, so thank you for making the time for our podcast. Let's start with, how did you first become interested in treating psychiatric illness during pregnancy and the postpartum period? Was there a formative case that piqued your interest in the topic or a clinical gap that you saw that you wanted to fill? What did your journey look like?
So when I was in residency nearly 20 years ago, the subspecialty field of women's mental health really wasn't much of a subspecialty at all. As a lot of us, I would assume, that have gotten into subspecialty niche areas, there was a specific patient case. In my situation, I was a PGY3 psychiatry resident, doing my outpatient year of care. And I had a woman come into my office for an intake who was pregnant. She had a diagnosis of schizophrenia. And at the time when I presented the case to my supervisor, I was advised to take her off her antipsychotic medication because of concerns for risks to her unborn baby. Given where I was at my psychiatric training, I had actually had the opportunity to take care of this woman the year prior on the inpatient psychiatric unit, and I had seen how poorly she was functioning at that point when she was off her antipsychotic medication and quite decompensated. And so that didn't make a lot of sense to me. So I actually went to my program director. I had a conversation with him, who advised me to go to the literature, do some of my own research, and ultimately come up with a plan that my supervisor could support, but also that the patient could support. And the patient had good insight and really did not want to come off of her medications or return back to a decompensated state. And so the little evidence that we had at that point, we did ultimately decide to continue her on her antipsychotic medication. And she went on to have a fairly uneventful pregnancy, successful delivery. She was able to parent that child postpartum then as well. So that was the case. And then ultimately what happened later is that my cohort of residents recognized that I felt comfortable caring for pregnant patients. And so I started getting a lot of referrals within our own resident clinic, and developed a little bit of an interest and reputation within my own residency program for that. And so started seeking out opportunities to learn more about reproductive psychiatry, women's mental health.
I think that is still how a lot of people are getting interested in reproductive psychiatry, women's health. I know where I trained in Omaha, there were several people in the community, residents, that had an interest in this. And it was like, hey, if this is what you want to do, great. And so you can kind of develop your own expertise as you go, since I think there's no ACGME accredited fellowship in this area yet. Is that right?
That is correct.
And I also appreciate you kind of sharing that vulnerability with our learners. I think that's so important to talk about times when, you are an internationally renowned expert on this topic and you had a really challenging case and you had a disagreement with the supervisor. And so how do you navigate it, right? You go to the channels that exist for quality control and making sure that you're supported in residency. So that's a really good example of thinking outside the box, pulling the levers that are available to you, and really kind of putting yourself out there to do what is right for the patient when you have a strong instinct that there's really a right way to go about things.
Absolutely.
One theme that's come up in your work is the complexity of treating two patients at once, the mother and her unborn or newborn child. How do you approach balancing those two lives when making clinical decisions?
Absolutely. I often times will talk to really anybody who will listen about the need for taking the pregnancy or lactation status out of the equation first and foremost when you approach a perinatal patient. And the reason I approach it that way is because if we don't have a healthy mother, that baby is not going to be healthy. And so, if this is a patient, I'm going to use an example of a bipolar disorder patient who is doing well on her and a mood stabilizer or antipsychotic, whatever the case may be, and you ask yourself, what would I do differently if she weren't pregnant? If the answer is nothing, that's a good starting point. That is where we should start, and then apply the evidence base to her current medications and go from there to see if it's compatible. Certainly, there are medications that aren't compatible or not as compatible from a safety perspective with pregnancy. But first and foremost, we should think about if this patient wasn't pregnant or breastfeeding, what would we do first and foremost? And then go from there rather than the opposite approach, which is I think a lot of what patients do or people do is just jump to which medication is safe in pregnancy. That's a backwards approach in my mind.
What I'm hearing from you is that you're really appreciating the risks of changing a treatment plan based on nothing else than a current pregnancy, right? If you are treating a patient with psychiatric medication, you have determined that it is medically necessary and that not having it on board will lead to a decompensation or a decreased quality of life for this patient. And so you're starting from that place of there are significant risks. It's not just what's safest for the baby, it's what are the risks of changing my treatment plan based solely on this emerging pregnancy. Is that right?
Absolutely, absolutely. And on the flip side, if this is a patient who say had a single episode of a major depressive disorder, and this is an appropriate time then to take her off of her antidepressant because she's had a period of psychiatric stability, well then by all means, let's go ahead and do that to minimize risk to both patient and that baby at that point. But we really need to be balancing the risks of her untreated psychiatric disorder along with the risks of these medications because I think we tend to focus a lot on the medication risk and we oftentimes forget about how severe the untreated psychiatric disorder, mental health disorder, substance use disorder can be for this patient, that unborn child, as well as that entire family unit.
It's a risk versus risk discussion, and it's also centered on really knowing your patient. Is this a patient who, if I decrease or stop their psychiatric medication, they're going to wind up in the hospital within a month? Or is this a patient who maybe has been stable on the starting dose of sertraline for a couple of years and has been interested in starting to taper that? Or are they somewhere in between?
Exactly. And so it's very hard to be able to have a blanket approach to this field because of all of those individual factors. And so when I get questions about which is the safest medication in pregnancy, I have to understand and know what's going on with that patient first and foremost to understand is this medication, which may have more data than another, is that the appropriate medication for her?
So, you've helped clarify for many the distinctions between some commonly confused diagnoses that some of our viewers may not be familiar with, such as baby blues versus perinatal depression versus major depressive disorder. I realize that this could be a long winded answer and its own lecture in and of itself. But could you walk us through some of the key differences between these presentations, especially in the early postpartum period?
For anybody who has heard me speak or lecture, they know that I lovingly call the early postpartum phase the hot mess mama phase. And I say that with lots of love in my heart. But it is truly because all new moms are allowed to be a hot mess for the first 2 weeks after they deliver a baby. And that's true whether or not they have a psychiatric issue, um, underlying diagnosis or not. And so, really, those first 2 weeks, that baby blues is a period of normal emotional lability. So, of course, there's going to be a ton of transitions going on. They're likely sleep deprived. They're likely in pain. They may be a new mother or adding another baby to their family, and a lot of role transition that goes along with that. Hormones are rapidly changing during those first early days. And what that can look like symptomatically is they may be more tearful, more anxious, have some sleep disturbances, be more overwhelmed and distressed. We have to recognize that this is normal. At least 70 to 85% of new moms will experience this period of time. And we also anticipate that by week 2 to 3 postpartum, that should stabilize, if not all the way back to baseline, nearer baseline. So if we're looking week by week, they should be getting back to their baseline. Also recognizing, however, that their baseline postpartum may be different than their baseline in pregnancy or even pre-pregnancy. Again, they've had massive role transitions that we have to account for. So that's those first early weeks that I call the baby blues. Lots of support, reassurance, education goes a long way. However, and I should say, it's not a period of time that I would actively start treatment. Other than maybe some social support, peer support, again, psychoeducation, it's very rare that I'm going to start a medication or even engage in psychotherapy for like a CBT approach during those early weeks because it tends to be self-limited. However, if those symptoms have not improved or had significant movement towards improvement by weeks 2 to 3 postpartum, and certainly if it's impacting their functioning, ability to care for themselves, ability to care for their baby, significant suicidality, at that point, absolutely, we're going to do that in those early weeks. But ultimately, we're waiting for 2 to 3 to 4 weeks postpartum just to see if those symptoms resolve on their own. And then diagnostically, obviously, a diagnosis of major depressive disorder still has that same diagnostic criteria that we would have at any other point in a general adult person's life. So we need at least 2 weeks of symptoms in order to make that diagnosis. So again, that's going to push us out at least until that 2 week piece. The only caveat to all of that would be if they were experiencing symptoms during their pregnancy and didn't want to start medications or kind of what I call white knuckling it through. And now postpartum has very much worsened those. But if they were doing well throughout pregnancy, delivered a baby, crashed and burned, then we're going to kind of see what happens in those first early weeks postpartum before we kind of jump in with long-term treatment.
Quick follow-up. Could you talk to us about the difference between major depressive disorder and postpartum depression or perinatal depression? How do you use those terms, or do you?
I don't. And so it's pretty rare for me to call a patient a postpartum depression patient because diagnostically, again, it's the same criteria that we would be utilizing for a major depressive episode. And in my mind, when I'm communicating in documentation or to another healthcare provider, it's much more specific if I'm talking about a major depressive disorder, recurrent, severe, with postpartum onset, perhaps. That's how I would utilize that qualifier rather than just minimizing it to postpartum depression. Does that make sense, Mark?
It makes perfect sense, and I think it's at a very sort of academic level and in the popular press, on social media. I think some shortcut terms are maybe used, but when you're actually the one practicing medicine, you should be using the terms of art, which in this case would be major depressive disorder with the appropriate specifiers, with peripartum onset, etc. I have to self-disclose here that my countertransference is raging today because I have a baby at home that is 3 weeks old.
Oh,
And what it has completely changed my understanding of perinatal mental health. It's our firstborn. One of the pearls that I have always loved to teach my medical students is there's this 2021 meta-analysis by Kishi et al. Looking at pharmacologic treatments for mania. And actually tamoxifen, which is a selective estrogen receptor modulator and protein kinase C inhibitor, outperforms all of our standard agents in efficacy for mania in terms of reduction on symptom scales, which is totally wild because we don't use tamoxifen for that, and we should not use tamoxifen for that. To be clear, that would be, this is not legal advice, but that would probably be malpractice. That data is based on 2 small studies, but that study has shaped the way that I think about perinatal mental health because I think about reproductive hormones in the brain. So I always have thought of perinatal mental health as more genetic and biological than I often think of other psychiatric disorders or especially depression in other populations. But then I encountered an infant who I am supposed to love deeply and am rearranging my entire life for and giving my entire life to, absolutely screaming at me for 48 hours straight at 4 a.m. And I thought, oh, I mean, any number of negative mental health outcomes seemed totally on the table in that moment, in those moments that are still ongoing. So I feel you when you talk about how hard it is to separate normal stress in this period, because anybody who's not sleeping for 48 hours and being screamed at is going to be a little bit down on themselves
Mhm.
from a mental illness that requires intervention. Are there any validated tools that you could recommend to us or kind of concrete clinical pearls for teasing out this distinction?
Well, we have a host of screening tools that we should be utilizing. I think the difficulty is the timing of utilization. So the Edinburgh Postnatal Depression Scale is probably the most widely utilized for perinatal depression, validated in pregnancy and in postpartum. The nice thing about that tool is that it has an anxiety subscale within it. So questions 3, 4, and 5, if you just look at those questions, can specifically look at anxiety. And then the screening tool as a whole, you can look at for depression. Otherwise, we're looking at the PHQ-9 or the GAD-7. Again, really validated in all of these populations. The key, however, is the timing. I love how you just talked about your newborn, Mark. And if you were to take that PHQ-9 or your wife were to take that PHQ-9 at day 3 postpartum, wow, right? Like, let's just think about what that's going to look like and how falsely elevated some of those could be given everything that has happened in those last few days. And so while sometimes the healthcare systems will advocate for screening at time of delivery, having had 3 kiddos myself and lived through that, don't ask me how I'm doing from a mental health perspective on day when I'm having to take home a brand new baby's life and in my hands, having been up for the last 48 hours and a ton of pain after giving a vaginal birth. Like, that's not appropriate in my mind. So I think we need to think about, obviously, utilization of these screening tools, but to do so at a time that makes some sense. So in my mind, that's at multiple intervals throughout pregnancy, and then with pretty rapid postpartum follow-up. And, I think we also should be thinking about what that postpartum follow-up looks like from a healthcare perspective, because maybe their first interaction and a lot of their interactions may be with a pediatrician. And so utilizing our pediatric providers, our family medicine docs that may be seeing that whole family and a lot of well-child care in those early months, maternal mental health screening at that point can be a really powerful tool to capture that, not just in those early weeks, but then well beyond that traditional 6-week obstetrical follow-up visit.
In moments where patients are terrified of harming their fetus, but also severely depressed, how do you navigate the tightrope between compassion, evidence, and patient autonomy? And I recognize this is a loaded question. So, more so in the context if, say, you may have to involuntarily hospitalize a pregnant mom.
That is hard. And I think that is hard for any patient, not just our pregnant population, no doubt about that. And so I think really getting as much education and support and rapport building for that patient, but also for her support system. And hopefully she has one. So is there a partner or her parents, siblings, somebody else involved that we can really get them on board to be able to see or allow her to see where her best self is and where she is currently. Sometimes that's really hard. And then recognizing that there's a lot of stigma for treatment for mental health or substance use disorders, again, in the general population. And I would argue even more so for our pregnant and lactating patients and taking medications and worried about, CPS, the Child Protective Service involvement, and what that could look like as well. And so I think education is really key about what your goal is, getting everybody on the same page, and then continuing to have that collaborative discussion with your inpatient team and her obstetrical providers, because I think that gets lost a lot. There's very few of us these days who you send somebody inpatient or are actually able to care for them inpatient. And then what does that wraparound plan look like? And what does that mean for her obstetrical plan if she happens to be hospitalized? Do we need to give education to our inpatient psychiatry team about options for appropriate medications? What about ECT or TMS? Like all of those conversations, to have those same players on the same page can be really helpful. And then making sure that there is a follow-up plan and wraparound services for all players, including her obstetrical team post-discharge.
Thank you so much for that. Definitely needs a full, close follow up in that situation, of course.
Unique population at significant risks kind of throughout pregnancy, postpartum, et cetera. And I'm definitely hearing that a collaborative approach is especially recommended in this patient, engaging their support system and making sure that we have a firm plan for how they're going to be helped beyond just medication after leaving the hospital. But let's talk about medication. I think this is one of the hot button issues that many clinicians find challenging in the perinatal period. Erica has some thoughtful questions for us on psychopharmacology in this population. Take it away, Erica.
Yes, of course. Thanks, Dr. Mullen. So, given the limited data, Dr. Wichman, how do you personally approach pharmacotherapy decision making during pregnancy as well as lactation?
I think the first point is that we probably have more data than certainly than what we used to. Um, and that data is ever changing and ever expanding. And so I would just caution and encourage everyone who's listening to really continue to challenge where your education is on the subject of perinatal psychiatry, because what we even knew 3 or 5 and certainly 10 years ago has rapidly changed. And so it's difficult to keep up with that within the entire field of psychiatry, let alone within a specialty niche as well. Really, I think the approach needs to be a risk approach. And what I mean by that is there was the risk of an untreated psychiatric disorder versus the risk of utilization of a medication. And those risks not only to the patient, but to her fetus and neonate then as well. I shared this earlier, but really kind of thinking about what would you do if this patient was not pregnant or postpartum? If she weren't pregnant, if she weren't breastfeeding, what would your clinical approach be to her? Start there and then apply the evidence base to that treatment plan rather than looking for a treatment plan and then trying to work backwards to see if that plan fits your patient. We always need to be patient centered first and then apply the evidence to that treatment plan.
Thank you so much for that. Which kind of leads me into my next question. And I guess you explained it in and of itself, like what your particular go-to antidepressant would be, say, in a lactating mother.
My go-to antidepressant is whatever's working for that patient,
Of
and
course.
really what has. um, and if we don't have that to go by, if this is a first episode, she's never had pharmacologic treatment, then again, take lactation out of the equation. Look at her constellation of symptoms. What makes best sense? Because all of the antidepressants, we've got good data that we can safely utilize them with lactation. And I think primarily what you're referring to is the relative infant dose, i.e., the transfer rate. But again, the other things that we need to think about, not just the transfer rate, but also the impact on milk supply, as well as the impact on ability to parent, i.e., sedation. So if we're utilizing sedating antidepressants, i.e., mirtazapine or sedating tricyclic antidepressants, we need to be mindful about that as well. But for the most part, we can safely use that entire class of kind of traditional serotonergic-based medications as well as atypical antidepressants in a lactating patient.
Awesome. Thank you so much for that. And I think you made such an important point about how the field is rapidly changing in and of itself. What resources do you recommend for people to stay up to date on the current literature on this?
Yeah, it is hard, no doubt about it. I think Mass General has a fantastic website, so womensmentalhealth.org. They've got a great website for patient-facing materials, mother2baby.org. Even ACOG and some of our subspecialty organizations have some good data. And I think honestly, for the ever-wrapping field, changes its conference attendance and engagement with conferences and kind of hearing what folks are out there and doing.
And then where do you think the field is heading in terms of new or even safer psychotropic options?
Well, certainly there's a lot that has been done recently with postpartum depression, specifically, if we utilize that term, and our newest medication specifically targeted for postpartum depression. And what I'm referring to that is zuranolone, which is, again, completely new medication only targeted for postpartum depression. And I know you can't see me, but I'm air quoting that. And that is the one time that I will utilize the term postpartum depression. And I utilize it there because of insurance issues. And so insurance will only cover those kinds of zuranolone for postpartum depression. Even if I utilize my, major depressive disorder with specifiers, that's not what they're looking for. They're very much looking for that term. Isn't that fascinating? Yeah.
I mean, it is and it's not. It's kind of par for the course, but
it
it is amazing
truly
that,
is.
yeah.
They're looking specifically for that. And so, in my documentation, I'll actually utilize both in that case if I'm trying to get a medication like zuranolone approved for my patient. So I think that's super exciting that we are having actually funding and research going into this topic because again, we've never had that before. And so you have specific targeted treatments for postpartum depression is phenomenal. I do think that looking at medications that are utilized in the general adult population, again, we're getting more and more data every month, every year about the safety of those medications throughout pregnancy and lactation as well. So again, it's just ever changing and typically in a good way that we're just getting more safety data that supports their use, particularly if we know that this is a patient that has not done well without a specific medication on board.
Thank you for making note of that. I think that'll be really helpful just for people to kind of gauge what to look forward to in this field. You also had an interesting case report that we saw, and I wanted to see if you could comment on the use of monoamine oxidase inhibitors, such as transdermal selegiline in pregnancy or lactation for us.
Yes, a big shout out to my consultation liaison psychiatry fellows who were the first authors on that paper. So both of those
Nice.
women, both of those women were rotating in the perinatal psychiatry clinic that I supervise when this case came across. And like a lot of things, there wasn't a lot of evidence one way or another. And so given her history and her failure of multiple different medications throughout the course of her lifetime, we did make the decision to go ahead and start transdermal selegiline, and she did well. She did well. And then we had looked at some markers for lactation as well and transfer into breast milk and tried to kind of get a little bit more data that way. But I think the bottom line with that case is really patient first and patient-centered approach. It's not uncommon that I get a question of, well, the patient's failed sertraline and escitalopram and a little bit of venlafaxine and bupropion. I guess I should just try another SSRI. Why would you do that? You wouldn't do that if she wasn't pregnant, right? We'd go on to either augmentation or a different class altogether, or really start to think outside the box. And we need to do the same approach with a pregnant patient as well.
Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice saves you time so you can focus on spending that time with the patient and not on writing notes. Simple Practice now has an AI-powered note writing tool integrated within the health record so that it's a true all-in-one EHR. Simple Practice is HIPAA compliant, it's high-trust compliant, and you'll also love the PDMP checks integrated within the portal and the easy-to-use lab order templates. Simple Practice saves you time so you can focus on what matters most. For a 30-day free trial of AI Note Taker and a PBC exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 USMLE Step 2 questions and over 4,500 questions for Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exams, and I found them to really reflect the real exam and make the exam a breeze. Give it a try. Beattheboards.com/bootcamp. This is reassuring for me to hear because everything you're saying is consistent with the approach that we were taught in residency to this population, which is treat them like everyone else, do a thorough, comprehensive psychiatric assessment, and know your formulation well, know the severity of the symptoms that you're treating and the risks of discontinuing those, take a risk approach. And then it's a very informed consent-driven approach, I think. It's very collaborative. It's what's going to work for you. These are the risks. We need to be upfront about the risks. We need to be upfront about the fact that there are some things that we don't know about these medications. I appreciate your point that we're learning more every year and we have a lot more experience with them every year, but there will always be some unknowns. There's always some unknowns in every area of medicine. But I think that psychoeducation piece with the patient that says, the best thing for your child is a healthy mother that can parent robustly. And this is what we need to do to allow the infant that gift. And so I think that we have some kind of black and white questions for you about algorithms and go-tos and decision trees. And true to your field, true to being a psychiatrist, you are rejecting that black or white thinking. And you're telling us that we need to know our patient comprehensively. And that's what this podcast is all about. So you fit right in.
And if pushed, I will answer those questions in a black and white capacity. I will. So if you really want me to do so, I will do so. I think the other piece that I want to comment a little bit on what you're saying is not just knowing your patient, but diagnostically being confident, because these are complex patients. These also may be patients that are referred to us during their pregnancy, and they're coming to us on a polypharmacy medication approach. And we're like, well, crap, Wichman said, maybe we just continue things if she's psychiatrically stable. But the other piece is that if that makes sense diagnostically for her. So we really need to be cautious of that. I think so much of my practice is ensuring diagnostic accuracy from those patients that are referred to me that maybe if we're diagnosed with bipolar disorder or ADHD and we're started on medications and seem to be doing well. And do we continue to expose them and their infant to a mood stabilizer or to a stimulant medication without having certainty of that diagnosis? So I think that's the other piece that I will reiterate of that as well. So not psychiatric stability is key, 100%. And that goes along with diagnostic clarity too.
For sure. I think those are difficult conversations to have. Just like a hospitalization for any patient that you see on consultation liaison psychiatry can help a patient to see the world differently because they're in a unique situation of being in the hospital and having to deal with stressors that are brand new to them. And so they have to be more mentally flexible. I would hope that a pregnancy, considering bringing another human into the world, would allow many patients the mental flexibility to consider things in a different way, to look back and say, was this the correct diagnosis? Is this really the indicated treatment? Just because it makes me feel good or because I'm afraid to discontinue it because I'm doing fine, does that mean that it's the most evidence-based approach? So that sounds like a difficult conversation to have at a real significant inflection point in the patient's life.
And it is, certainly that is my experience clinically, is that patients are much more willing to have those conversations and maybe much more willing to engage in non-pharmacologic approaches than they previously had been. I give the example of sleep a lot. Patients come to me and they've been on chronic nightly sleep aids for months, if not years, and they'd like to continue that throughout pregnancy. And my pushback is, sure, we can talk about that, but what are you going to do postpartum night 3 when you're at home with a baby? Are you going to take your sleep med? And they just kind of pause and say, I hadn't thought about that. No, so let's do that. Can we work in the next 7, 8, 9 months to get off of a scheduled sleep medication and have more engagement with sleep hygiene, CBT for insomnia, those kinds of pieces. And so I do see that cognitive flexibility for both the treatment options, but also for the diagnostic clarity piece.
I love that. Thank you for that example. Let's talk a little bit more about these non-pharmacologic options that you brought up. Erica, I'm going to ask you to launch directly into that question.
If you only had 10 minutes on a consult to offer non-medication recommendations for managing mild to moderate perinatal mood or anxiety symptoms, what would your top suggestions be?
Sleep, sleep, and sleep.
Don't we all need
so
it?
sleep right. Don't we all need it? And these mamas need it too. But they also need very specific examples of how to make that work, right? This baloney of sleep when the baby sleeps. Poor Mark is living it right now, right? Like, it doesn't work.
I'd have to apologize to my wife in a major way. So I'm very interested in what comes next. Save me.
All right. So yes, that sounds like a lovely concept. And the fact is that it just doesn't work that way. And so what I really propose is, how can you be intentional about sleep shifts is the concept that I talk about, right? Especially if there's a partner or support or a loved one that parent can lean on to be able to provide support. So what we know is that patients who are sleep deprived, general patients, will not do well. And our postpartum mamas, there's good research to show that if they can get consolidated sleep, they're going to have less of a risk of depression and or anxiety. And so there isn't great data to say what is that cutoff. Most of us who practice in this field say aim for 4 hours of uninterrupted sleep at some point in a 24-hour period, particularly if they are having symptoms of depression and anxiety. I think it's even more important and probably a longer period of time if they have an underlying bipolar disorder diagnosis. But even for prevention, this has been shown to be helpful. So what does that look like logistically? How do you do that, particularly if there's breastfeeding involved? So I think number one is, are they willing to not exclusively breastfeed only via breast? I think those conversations go hand in hand. Do you introduce a bottle either with supplemental formula and or express breast milk to allow that mom to go in a separate room, earplugs, eye mask, noise machine, and allow her to get 4 hours of uninterrupted rest, and then come back and then do, take the night shift or whatever, but actually being thoughtful about those 4 hours. How are you going to ensure that's going to happen? And what is your tag in and tag out approach? A lot of patients tell me, well, my husband works, third shift, or my mom can only be here in the afternoons and I'm a single parent. Great. No one says it has to be at night. How can we structure 4 hours of uninterrupted sleep or rest in a 24-hour period? And we can make that work for you. These are not conversations to have postpartum day one or postpartum week one, or when they're in the throes of a postpartum depression. This is where planning comes in. With that 9 months that they're pregnant, if they're seeing a mental health provider, they are at risk for development of worsening depression and anxiety symptoms postpartum. And so let's have those conversations as prevention. So there was another long-winded answer for your 10 minutes, but that's really what I would focus on is that sleep piece.
Thank you. I think that's very necessary to get into context for sleep being important, especially for our young mothers.
We've talked a lot on this podcast about building therapeutic alliance and about how one way to do that is to demonstrate expertise and to tell your patients, this is what's worked in other patients. This is what other patients have told me. This is kind of the illness script. This is what typically works. Does any of that connect with you? And oftentimes the patient might say, oh my gosh, someone actually understands my experience. This person actually knows what they're talking about. That's actually my life. And I got to tell you, Dr. Wichman, that's actually my life. And I'm having that moment right now. I may have to create a TikTok just for this, just for that one clip, because the world, and certainly the Mullen family, needs to hear that message. Thank you so much for that hard-won expertise. So if you had 10 minutes, it's sleep, sleep, sleep. What if you had 15 minutes?
Ooh, the other thing that tends to go by the wayside is their own self-care. And that can be, that's pretty broad. I get that. But if these moms are so focused on their tiny humans, What about their own nutrition? What about their own, obviously, exercise can be kind of a big goal, but getting out in the sunshine, having a little bit of space, getting a shower. I mean, a lot of that can seem really monumental in those first early weeks, but having some of those necessary self-care. And then what's that step up? A lot of times I encourage patients, despite virtual practices, to come into my office with or without baby. And then when they leave my office, please go through the Starbucks drive-through. Like, take a minute, right? Take a minute, and that's okay. Or whatever small thing that's going to bring you joy. Can you do a Target run and leave the baby at home just for, again, not to say a Target run self-care, but a little bit of time and space, and allow you to have some self-care, whatever that looks like, and working with your partner and support to do that. So again, it's all of that thoughtfulness about the sleep piece. We can continue to have that thoughtfulness, and how do you structure that in those early weeks? And that structure, so maybe if I have 20 minutes, what does that day look like for a structure? Particularly for women who were working full time, were up at a specific time, had a very much structure throughout their day, and now are thrown into, the structure is none at all, and just caring for this tiny human that needs everything and isn't going to be anything back to you. So there's not a whole lot of structure with that, and a lot of women do thrive on that. So how can you build that into that maternity leave to allow you to have a little bit of control over what your days are looking like too, can be incredibly powerful, incredibly helpful.
That's so good. Thank you so much. Go ahead, Erica, on to the next one.
You have emphasized in your work the importance of distinguishing between intrusive thoughts, often seen in anxiety or even normal in very stressful situations, compared to psychotic symptoms, which may require an emergent intervention. My question for you is, what are some red flags that make you lean more toward perinatal psychosis as opposed to intrusive thoughts?
So intrusive thoughts very much are related to a primary anxiety disorder, whereas psy- thoughts surrounding harm to themselves or around to an infant are much more related to a psychotic disorder. And the timing is different, and how they present is different. So a true postpartum psychosis is going to be very early postpartum. Typically, we're going to see prodromal symptoms within the first 3 to 7 days post-delivery. Oftentimes, very strongly associated with a bipolar disorder type 1. So if they have a known diagnosis of that, we should be looking for development in those early days and have a very close postpartum follow-up because of that. But I think the most important piece is the distress behind it. Women who have a psychotic disorder don't have the insight to recognize that the thoughts they're having aren't normal, for lack of a better term, that they don't recognize that those thoughts should be distressing to them. Versus a woman who is having intrusive thoughts secondary to an anxiety disorder, she's incredibly distressed by those thoughts. She recognizes she shouldn't be having those thoughts. She's going to go to great lengths to avoid having those thoughts. And oftentimes that means avoiding the baby. But she has rational thinking about that, and she's grounded in reality. Versus my patient who has this underlying psychotic disorder and has more psychotic thoughts of harm, does not have that reality base. For those of us who practice in an outpatient setting, I've done this for a very long time. I've never had a patient walk into my office that has a primary psychosis with psychotic thoughts. That's not where they present, right? They're presenting to the ER. They're coming into the hospital setting. Much like our very manic or psychotic patients, they're not organized enough to get to an outpatient appointment. It may be that their family's calling and saying something's not right. But in that case, that is a psychiatric emergency that we need to get to an emergency room for emergent psychiatric evaluation.
Okay, so let's shift gears to focus on the Periscope project that you helped pioneer, one of the most, I would say, innovative models in the country for supporting frontline providers in delivering perinatal mental health care. Can you tell us more about how this project works and what gaps it's helping to fill in the maternal mental health care field?
So the Periscope Project is Wisconsin's statewide perinatal psychiatric access service. And we provide that service with three main components. The first of which is real-time teleconsultation for any healthcare provider caring for a patient with a mental health or substance use disorder, and linking them with a perinatal psychiatrist in real time. The second component is community resource information. So myself as a practicing psychiatrist in Wisconsin, I knew there are a lot of resources out there specifically for this patient population. But I myself as a psychiatrist couldn't keep up with which ones were active, which ones still had funding, which ones my patient's insurance would cover. And so our database captures that. And it's our job at Periscope then to keep that updated. At least every 6 to 12 months, we reach out to those resources and ensure the accuracy of those perinatal mental health and substance use disorder resources in our community. And lastly, it's education, right? It's providing education really to anybody who will listen about perinatal mood and anxiety disorders and substance use disorders, both via our website, modules, webinars, our algorithms. So things that can live in our website, as well as on-demand virtual or in-person didactic series that we can tailor to a clinical setting. The most prominent portion of this work is that first component, that teleconsultation component. I think it's best described by just kind of walking through what this is. So essentially, a healthcare provider has a patient in their office. We're going to pick on a pregnant patient with an anxiety disorder who self-discontinued her citalopram at time of conception and now is presenting with symptoms of anxiety and depression, panic attacks, and her obstetrician isn't sure what to do, right? So that obstetrician can step out of the office, step out of the room, pick up the phone, call her 1-800 number, and be connected to me or somebody like me within 30 minutes. And then we have a case-based conversation. It's just like if you and I met in the hallway at the hospital and said, "Hey, Wichman, I just want to run this case by you. What are your thoughts?" So I don't have access to the patient. We don't look into the patient's record electronically. It's just that case-based conversation with the provider. And I say, "Well, have you thought about this? What about this history?" So I get some information and we just have that case-based discussion. And the goal of this program is to be able to educate that provider, empower them, and give them the confidence to take first steps for navigating a patient's mental health and substance use disorder in the perinatal period. So that doc can walk back into that room and say, "I feel much better about restarting your citalopram. Here are the risks at this point in your pregnancy. Let's get you a little bit of sleep with some duloxamine. How about a PRN medication? And let's get you a referral to a therapist or a peer-to-peer support group so we can send those options as well." So the whole time piece, so by the time we call back and we have that case-based discussion, really the whole thing should only take 20 to 25 minutes in totality. But you're saving hopefully a lot of time by not just referring. And we're not saying don't refer, but can we use this program to bridge to referral, given the long wait times? Or just to save that referral at all, because we know a lot of women may just get better with that initial treatment option. And then we're empowering them to stay within their practice then so that they can continue to have that rapport with the providers that they know and trust. And then the most important piece of this program is that the knowledge that they learn from that single encounter, they can then apply to their entire patient panel. Right? So if I did a 10-minute little mini lecture, here we are about SSRIs and pregnancy, let's go back to the one that's most effective. The patient that walks in next week with a similar presentation for depression, they don't have to call me. I've already taught them that. So they can apply that knowledge to their entire patient panel. And that's how we're educating our frontline providers to be better empowered and confident to care for these patients.
Quick follow-up. This is incredibly innovative, and I'm floored by how practical and effective I'm sure this is. Is this available just to people in your health system, just to people in Wisconsin? Who is this available to?
Yeah, so the Periscope Project is specifically for the state of Wisconsin. So when we started, we were the second state in the country to have a similar program. So Massachusetts was the first. Massachusetts and Wisconsin are very different, both geographic-wise, politically-wise, funding-wise. And so we had to do significant adaptations to the program. We kind of looked at their program and said, "Oh, that's not going to work for us. What will?" And so we adapted it to us. And now subsequently, there are over 20 states with similar programs across the country. That being said, if your state is not one that has a perinatal access program, Postpartum Support International does have a national program. It doesn't have the real-time consultation. You have to call and make an appointment for a consultation, but there is that availability to connect with a perinatal psychiatrist, regardless of where you are in the US.
From a systems perspective, what do you believe is the most critical change we need to make in order to reduce disparities in perinatal psychiatric care?
So I'm pausing.
You can
I
pass.
know. No, I don't want to pass.
We can edit it all. You can pass.
It's hard because my brain goes to, well, we need screening and prevention, and we need a much better job of consistently doing screening and prevention. Particularly, I would argue, with substance use disorders. We're doing a terrible job with our substance use disorders when it comes to disparities, and who we're screening versus screening everybody, which is what we should be doing, is screening everybody. But then on the flip side, when we diagnose and we get treatment options, we also don't have enough programs, people like me, SIP programs like I run, to be able to get people the treatment that they need and deserve then as well. My answer to that always is they're still going to be struggling with depression, anxiety, bipolar disorder, substance use disorder, whether or not you ask. We might as well know and do and figure it out so that we can support them in any capacity that we can with the services we do have available. So I do think that universal screening, consistent universal screening, really does need to be first and foremost. With what we know is killing our mamas, right? During pregnancy and postpartum, the leading cause of maternal mortality in the US for preventable maternal mortality is overdoses, primarily secondary to opioid use disorder. So if we put more resources there in creation of programs to support our patients who are struggling with opioid use disorders, particularly with pregnancy and postpartum, harm reduction models, et cetera, that's going to probably save a lot of lives. But we can't get there and figure out who they are unless we're doing a really good job with screening, identifying patients, and getting them hooked into the resources that we need. So it really is, in my mind, an approach that needs to be tackled by a lot of different sides. And so I really struggle with just naming one, unfortunately.
I'm really glad that you mentioned that. I think particularly across the whole United States, there's so many regions that are trying to tackle improving the maternal mortality rate and how we can address taking care of our people living with substance use disorders. So I think raising awareness for that, finding resources for that is a crucial step that people need to pay more attention to. And finally, Dr. Wichman, I have to just mention that I'm so honored to be able to interview you. I am interested in reproductive psychiatry. I'm a fourth-year medical student, and you've helped so many people, patients, learners, and systems. So for residents and early career psychiatrists who are interested in women's mental health, what kinds of training opportunities or fellowships would you recommend exploring?
I think exposing yourself in spaces where there's going to be overlap is actually fairly easy. So we know that 20% of women who give birth are going to be struggling with a mental health or substance use disorder. Do your obstetrician, do your OB rotation, do an MFM rotation, see those patients. Absolutely. Psychiatry, again, half of our psychiatric patients, if not more, are women, right? Learn about that entire spectrum. Be an advocate or a voice to be able to talk about these issues. Ask your resident, ask your faculty member as a junior learner, what's our preconception plan for this patient? Is she hoping to get pregnant in the next year? You can be that advocate for that patient as a learner and then start to spark those conversations as well. Certainly looking at trainings that are available, again, Mass Gen or what our Periscope website, conferences that are specific to this unique niche are fantastic as well. I have a lot of learners that come to me and say, do I choose OB or do I choose psychiatry? I did that a long time ago, and I chose psychiatry because I like my sleep. We've talked about sleep. I decided I liked my sleep. And I never would have thought as a fourth-year medical student that I would be doing what I am doing now. I went to medical school thinking I was going to be an obstetrician. I fell out of love with OB during my clinical years, and I came back to this intersect because I fell in love with psychiatry and this intersect with women's mental health. As far as kind of fellowships, there aren't ACGME accredited fellowships in women's mental health. It's not to say that there's not fellowships, because there are. I will wholeheartedly say my bias as a consultation liaison psychiatry fellowship director myself. I tend to steer students and residents towards a CL fellowship because of that broad base and the fact that they will have an ACGME accredited fellowship. And if their interests maybe change or morph over time, they've got a little bit more flexibility with a CL fellowship versus a women's mental health fellowship. And I love women's health, and I think everybody should know how to treat it. And I still think that there's some utility in thinking a little bit broader base with a CL fellowship versus a women's mental health fellowship. It's just all a matter of finding a fellowship program that is going to align with your needs and allow you to do some focus in that subspecialty niche area. That's what my program director did for me a very long time ago as a CL fellow. I was allowed to develop perinatal psychiatry rotation within OBGYN, and it really just grew from there.
Thank you. That's so awesome to hear, especially because so many people don't know about reproductive psychiatry. As you mentioned, it's not yet ACGME accredited, but I know that a lot of programs might have concentrations in women's mental health and different routes of that nature. So that's helpful to know.
One thing that I appreciate from your perspective here is it's very consistent with what I've heard from everyone who has developed expertise in this area. And I think a lot of subspecialists in psychiatry in general, which is, yes, you can. Yes, you can develop your expertise in this area. Yes, you can treat these patients if you're willing to do the extra work, go to the conferences, do your self-directed learning, because these patients exist. And there is nowhere near enough people like Dr. Wichman who have, published plenty in this area and been an international leader in developing reproductive psychiatry. There are just too many patients for Dr. Wichman and her few peers kind of on that level to see. And so that's why we're going to give you these resources. And I really do think the same goes for a lot of other subspecialties of academic psychiatry. In fact, had a couple of very good recent articles about training all psychiatrists, general psychiatrists, who know how to handle complex patients because they know how to do self-directed learning and where to go with these resources. So thank you for encouraging us to be uncomfortable and to do the extra work to care for this vulnerable population. It's certainly very encouraging for me to hear, as someone who works on a CL service, that the resources are out there, and I really can do this, I guess. Dr. Wichman, we've taken up enough of your time. Any final thoughts for our audience?
Preconception planning is my favorite kind of consult. Do a lot of that. So if you've got a reproductive age woman, ask if she is planning to get pregnant in the next year. Ask about her preconception plans. And follow up appropriately. If she's actively trying to get pregnant, great. Go ahead and give her some guidance about what you would do with meds at that point. And if you're not sure, then just pause and say, you know what? I'm going to do some research, but when you get pregnant, call me first. And if she's not trying to get pregnant, ask the follow-up question, what is your plan to prevent pregnancy? And be documenting that as well. That is well within our scope. All of us should be doing that.
Awesome. A pound of prevention, as they say.
100%.
Erica, any final thoughts for our audience?
I did like the speech that you gave, Dr. Mullen, about yes, you can. And I feel like, especially as people are researching more what they're interested in, find the intersection or find something that can inspire you or target the patient population that you're interested in.
Awesome. Well, thank you so much for coming on the podcast, and I look forward to talking to you next. Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.